So today for our journal club, we have Dr. Michael Young, 6-year neurosurgery resident, as well as Sarah White, first-year medical student. And they're going to be presenting on a topic, the paper Neck Remnants and the Risk of Aneurysm Rupture After Endovascular Treatment with Coiling or Stent-Assisted Coiling, Much Ado About Nothing. Dr. Young's background, as I mentioned, he's a 6-year neurosurgery resident at the Carle Clinic Neurosurgery Residency Program, previously called Advocate Health. His specialty interest is open cerebrovascular and endovascular neurosurgery, which is kind of what helped drive the topic in the article of choice for this week or this month. He has 15 publications in one book chapter, all focus on endovascular neurosurgery and neurosurgical trauma. After his residency, which he will finish next year, he's going to be entering a fellowship at Beth Israel Medical Center, which is a affiliate place of Harvard, and it's going to be an endovascular and operative neurovascular surgery. So we're glad to welcome Dr. Young. Also, we have Sarah White. She's a first-year medical student at Campbell University School of Osteopathic Medicine. She did her undergrad at Baylor, where she got a Bachelor of Science in Neuroscience, and she also was president of the Neurosci Honor Society. She's now a commissioned officer in the Navy and working towards a career in neurosurgery for active duty and retired service members. So without further ado, I'll let Dr. Young say a couple of words if he'd like to, and then I can let you go ahead and get started.
Yeah, thanks, Edwin. I first off want to just commend all of you that have put the NERG group together. And, when I first heard about it, I was actually listening to the Neurosurgery podcast. And as soon as I got off, I emailed Eddie, because this is exactly the type of group that I was looking for when I was in all of your position, in medical school, and it just didn't exist. There was no help, no support for, fellow DOs or IMGs or, other medical students that have don't have a home neurosurgery program to provide their mentorship. So I definitely, I'm happy that you guys have started, hit the ground running with this thing. And I think it's definitely something that will provide a benefit to everybody, if not everybody, matching into neurosurgery, but at least giving them some advice and getting them exposed to the field. Because, in medical school, you just don't see neurosurgery that much. And especially if you don't have a home institution that has a neurosurgery program. So kind of going off of that, the reason why I chose this article is obviously this is my subspecialty and a passion of mine. But I also wanted to kind of, for the medical students out there that are just kind of interested or starting to become interested in neurosurgery, or even just exploring other surgical specialties, to show that another field of neurosurgery, and it was certainly a field that even, I always wanted to go into neurosurgery, but once I discovered endovascular neurosurgery, I really knew that I wanted to do a combination of open and endovascular neurosurgery. So this paper kind of will, it's a little, detail oriented and maybe a little deep for this journal club, but I thought it was a good paper to kind of explore the field of neuroendovascular surgery, and we can expand upon that once we go through the article.
Cool. Well, thank you, Dr. Young, for providing the article. I know that as I went through it, I learned a lot from it. So I'm hoping everybody else gets a lot from it as well. I guess I'll go ahead and start. Let me share. Here we go. All right. So here's the title again. It's a mouthful, but I wanted to start with just some kind of facts about aneurysms in general, just because I know whenever I was going through this and looking stuff up, it caught my attention. So I thought it was important just to kind of add some, general things you would want to know as a practitioner about aneurysms. So 1 in 50 people have an unruptured aneurysm. So they're just walking around, it could go anytime. So that's kind of crazy. And some of these other things you want to look for warning signs and, risk factors and stuff like that. I'll just kind of let you all read that. But yeah, so let's crack this bad boy open. So the aim of the study was to directly evaluate the risk of rupture after treatment, solely due to the fact that there are neck remnants. So neck remnants would just mean that in the endovascular treatment, the aneurysm wasn't completely occluded. So there's still room for blood to flow into the aneurysm, which runs a risk of it rupturing. And so how it works is they run a catheter up through the femoral artery. Dr. Young explained this a little bit to me the other day. They run a catheter up, and it's kind of like a telescope system where a smaller catheter comes out of that after it goes past the aorta, and then you run the coils through the microcatheter to fill that aneurysm. And this is something that I learned just now from doing this paper. So I thought it was very cool, just to kind of get a picture of what this treatment looks like. But sometimes, so like in this top picture here, they'll place a stent in the blood vessel just to keep the coil from being lodged back out into blood flow. So that's the endovascular technique. There's another technique for aneurysms, and that's this. It's shown in this second picture down here. This the clipping, this microsurgical clipping, where instead of filling up the aneurysm, they just take a clip and close off flow to it. So it's more effective, but it's definitely more invasive because they have to go in. When they do the endovascular rupture, so post-treatment rupture, when the aneurysm is occluded, is only 1.1%. And then when it's not fully occluded, it's much higher, so 5.9%. So a lot of studies are saying, well, when you're doing the endovascular treatment, when you don't fully occlude the artery, then there's a much higher risk of it rupturing post-treatment. So that's why this study came back and wanted to directly evaluate that because there's a lot of talk about it. And so how they did that is they took 1,292 just endovascular treatments from 4 institutions where they have a lot of that data just because they prefer the endovascular method over the clipping. And so after treatment, they used digital subtraction angiography so DSA, to figure out if these aneurysms are completely occluded or if they're missing some coil, and so then blood can still flow in there. So these are the different classes. So you can just tell by the picture that they're not fully occluded, anything other than class 1. And so the primary outcome, like I said before, what they're really looking at is the risk of rupture, or they're looking at the post-treatment rupture after treatment in these 626 aneurysms that were not fully occluded after treatment. And some of the variables that they wanted to look at that they thought might be predictive of this was rupture at presentation. So the patient came in, the aneurysm was already ruptured. The aneurysm size and the location, the treatment type, so stent-assisted versus not, and then patient age and smoking status. So, and we'll look a little bit deeper into these methods too. So the treatment, how they decided the treatment, it was pretty much determined by the physician, but they, like I said before, it was kind of default. So they, especially at these 4 institutions, the endovascular method was going to be used unless it was considered unfavorable, and then they would do the clipping. And coiling versus stent-assist was also determined by the physician, but first choice for acute rupture and then stent-assist if the physician felt it was needed. And then in the study, they didn't differentiate the type of coil, so it can be different kinds of metal that they use to fill that aneurysm. So how they analyzed was, like I said before, they're looking at the incidence of post-treatment rupture, and the variables that they tested were, like I said before, rupture presentation. So the patient comes in and their aneurysm is already ruptured. The size, so they just split them up into these three categories, but it doesn't mean much. It's a continuum, obviously, but so either less than 10 millimeters, between 10 and 25 millimeters, and greater than 25 millimeters. So in other literature, they mentioned this in the article that greater than 25 millimeters for an aneurysm is known as a giant aneurysm. So keep that in mind. The aneurysm location, so anterior, posterior, treatment type, like I said before, whether there was Stent-Assist or not, patient age and smoking status. So first they did the Fisher exact test to determine if there was a relationship at all between post-treatment rupture and any of these variables. And then they used univariate regression to determine how closely they're related. And then the multivariate regression was to determine how closely more than one individual variable was related to post-treatment rupture. So this is just a look at the numbers for each category, for each of the variables. So a lot of them are pretty even, except for, well, posterior circulation. And one important one is this, the fact that, like I said before, the primary method was the coiling versus the stent-assisted. So there were only 147, since that was the kind of the default was the coiling, and stent-assist was only used if the physician felt needed. So there aren't as many cases for that. And then obviously most of the aneurysms were less than 10 millimeters. And so what they got was with the Fisher exact, they found that, well, so of the 626 that aneurysms that they analyzed that were not fully occluded right after treatment, only 13 of them ruptured afterwards. So that's already a pretty low number, which is good. But what they found with the Fisher exact test was that the most significant one was rupture at presentation. So if it ruptured at presentation, or it was already ruptured when patient presented, then they treated it, and if it wasn't fully occluded, then most of them ruptured again. So 11 out of the 13 of them. And then another one was the coiling without stent-assist. So all 13 of those were coiling and not stent-assisted. And then size was another predictive variable just with that test. But they, like I said before, they ran the univariate analysis and the multivariate analysis. So those look a little bit different. So right here, this is the univariate. So the univariate analysis came back saying that because of the low number of the stent-assisted coiling, there really was not a significant finding to correlate to that. So that really wasn't the focus of the study. So it might suggest that the stent-assist could help with preventing post-treatment rupture, but it wasn't significant enough just because of that small sample size. But then it did confirm the rupture at presentation, and it did show that age was another predictive variable. So increasing age, increasing risk of post-treatment rupture. And then the third analysis, the multivariate, that just confirmed these three, the rupture at presentation, age, and the size. So, so what they're saying they took from what they found was that, well, first of all, the reason it was important is because it's up to 60%. So I think I said 20 to 60% of aneurysms treated with the endovascular method end up with neck remnants afterwards. And so one of the studies that they talked about was this Carle study that said that pretty much it's due to the fact that these aneurysms aren't being completely occluded, which, as we've seen before, are a lot, up to 60%. So if, one study is saying that if they're not completely occluded and all of these aneurysms that aren't completely occluded, they're just going to rupture afterwards, that's really bad. So, but then there's some controversy. So other studies found no significance between post-treatment rupture and incomplete occlusion. And then another study, they looked deeper into, kind of the nature of the incomplete occlusion, and found that type 3B, which was a different classification in that picture we saw before in the methods, that just that type is more predictive of post-treatment rupture. So this study was just important to kind of clear up a lot of that controversy and confusion. And so overall, what was really kind of highlight was that only 0.6% of the aneurysms that presented unruptured of the incompletely occluded coil technique, they only 0.6% of them ruptured post-treatment. So that's super low. And compared to 3.4% of those that were ruptured at presentation. So that was kind of the biggest variable there that they found was more predictive of post-treatment rupture after endovascular treatment if it was not completely occluded. And so 11 of them, those were presented already ruptured, and then the other two that ruptured post-treatment that did present as unruptured originally, they were those giant aneurysms that I was talking about before, the greater than 25. So that was another thing that suggested, okay, well, this is a big aneurysm. So, and I think the most interesting part for me was that that they're pretty much saying it's not worth running the risk of trying to completely fill the aneurysm, because there can be complications with that, and especially if the patient is presenting with an unruptured aneurysm. So, and Dr. Young can talk a little bit about this part too, but pretty much what they're saying is trying to force that last bit of coiling can, have complications of its own. So if it's only 0.6% of a risk that, fully closing off that aneurysm is going to rupture post-treatment, then sometimes it's not fully worth it to try to force it in, because that could also lead to complications. So that is all I've got on the article. Did y'all have any questions, comments?
Yeah, I think that was a great job, Sarah. I think you did a very nice job presenting that article that, like I said, might be a little bit more technical than I initially anticipated, I guess, for this group. But I think you did a great job with tackling it. Kind of just to go through endovascular treatment and actually the history of treatment of aneurysms. I guess we'll start back with that. It's aneurysms were originally treated with clipping back in the 1920s by Walter Dandy, who I don't know if you guys have heard of. He's one of the fathers of neurosurgery. But anyway, classically, clipping was always the treatment for aneurysms, and it was up until the up until the 1990s. I'm sorry, where Guglielmi introduced these detachable coils to go into the aneurysm through the endovascular side. And at that time, that was, kind of thought of as kind of groundbreaking by some, but also by, old school open neurovascular surgeons as kind of, lucrative and outlandish to treat it that way. And now we've evolved so much where this is the primary treatment for most all aneurysms. Now, there's still a good and I won't go into, the morphology and location and such. I'll let you guys read about that. But what aneurysms are treated best surgically, open surgically. But, if you're a patient or you have a loved one or family member and, they have an aneurysm and we can offer them treatment to go through the femoral artery or the radial artery in the hand and treat the aneurysm almost as successfully as we can open, I think almost everyone would try and avoid a brain surgery if they can. So the reason this article is incredibly important is because the criticisms historically of endovascular treatment are, well, you're leaving these neck remnants, which with a clip, you're not going to leave a neck remnant, because with a clip, you're actually intraoperatively, you can visualize the aneurysm, you dissect it off the parent vessel, and you can place a clip directly across the neck. And I have some videos that I can show if we have time of exactly what that looks like. So that treatment, you don't ever have really a neck remnant. Where when endovascular came along, they're like, well, we shouldn't be leaving neck remnants because these can rupture and then lead to, the morbidity and mortality associated with aneurysms that you briefly touched upon. So this paper highlights that actually those that, as long as they haven't ruptured, because ruptured versus unruptured aneurysms are kind of two different pathophysiologic mechanisms. And once again, I won't go, that's kind of even more technical. I won't go into that, but I think that's why this paper is of utmost importance, because it kind of justifies endovascular treatment in a lot of unruptured aneurysms if able to be done safely. So nice job presenting it.
Thank you.
Great job, Sarah. Thanks for that clarification, Dr. Young. I think I'll start out with the questions. I do have a question. I saw that the mean follow-up time was 7.3 months, ranging from I think 1 to 84 months. What kind of time frame are you guys most concerned with post-treatment rupture from an endovascular technique, and speaking to that also with the open technique?
Yeah, so that's a great point, and I was actually going to talk about that. That's one of the shortcomings of this paper, is it's a very short follow-up. So I'll just explain our typical regimen. So yesterday we did an open surgical treatment of an aneurysm, and this morning we did an angiogram to make sure that that aneurysm was all gone. That patient will then get another angiogram at 6 months and then a year, and then they'll get CTAs for the next yearly for the next 5 years. So we do see with open surgical, usually when there's no neck residual after clipping, we don't see any recurrence. Now, with endovascular treatments, there's a much higher recurrence rate, and that's what some of the landmark trials, such as ISAT or BRAT, which were briefly mentioned in this paper, they showed that you have to actually follow these endovascular treated aneurysms much longer. However, if there is a neck remnant, even up to the BRAT trial just published their 10-year data, and they showed that initial neck remnant that they saw at their 1-year data was stable at 10 years. So the risk of rupture is low, but there's still an unease about seeing some aneurysmal filling from a lot of the vascular community.
Awesome, thank you for that. Looks like we have a question in the chat from Jordan Clemens. So it says, so how through endovascular means do you ensure a tighter occlusion for those ruptured aneurysms to avoid clipping?
That's a great question as well. So there's so many more advancements in technology that have come out, even in the last 2-3 years, with the treatment of aneurysms endovascularly. And in terms of coil, there's something called coil packing density, where we want to tightly pack that aneurysm dome as tightly as we can without avoiding prolapse of any coils into the parent vessel. And there's multiple devices that we can use to do that. One of them, in which Sarah touched upon, is stent-assisted coiling, where we actually go in with the microcatheter, start coiling, and then we deploy a stent in the parent vessel so that that coil cannot prolapse out into the vessel. It will hit the stent and actually stay up in the aneurysm dome. And once again, I have, plenty of case examples to show this. If those that are, I'm a visual learner myself, so if people want to see more visual cases, I can show those. But that's one way. The problem with that is you have to put patients on antiplatelet therapy. Well, if they just had a subarachnoid hemorrhage, it's not necessarily the greatest idea to put somebody on more blood thinning medication, because they might have an external ventricular drain for their hydrocephalus, for their intraventricular hemorrhage, or they might need a VP shunt, a ventriculoperitoneal shunt down the road, and that could put them at a higher risk of hemorrhage then. There's further devices called a Comanici, which is a stent-assisted, a temporary stent that goes into the vessel, and then you can coil real tightly, and then you can actually remove that stent. There's even intrasaccular, what we call flow disruption, where we actually place like a balloon within the aneurysm, no coils, and that's really good for ruptured aneurysms and helps prevent re-rupture, because we don't put them on any antiplatelets either, because it's all within the aneurysm. But that's a great question. Sorry, it's a long answer to that question. If you can't tell, I'm pretty passionate about this field, so I have a lot to say about it. But, it's all about coil packing density, ultimately. If you can get that coil packed as tightly as possible, that's going to help prevent your risk of recurrence and re-rupture.
So Eddie, I actually have a question. I don't have the hand raise feature, so I'm going to jump in.
No worries.
Thank you, Dr. Young, for coming to this talk here. I am not a medical student. I am just the research associate. So I do have a master's degree, but I don't have medical background. So the question that I have, and this might be silly, I'm not sure, but if it were to rupture, what happens to the coil? Right? It's now loose, right?
Sure. So sometimes we see when these do rupture, there's actually coils sitting in what's called the subarachnoid space, which is actually where all the vessels live. They don't live, these larger vessels, they don't actually live within the brain tissue themselves. They live in the cisterns, we call them, which is the subarachnoid space. So yeah, we've actually seen before, if it does rupture, there's a little outpouching. It's not like the coils fly out and they go downstream or anything like that. Because what happens with a rupture is it ruptures and it bleeds for a little bit, but then the body's natural clotting mechanisms take over, and there's a clot that will form at that site. So you might see just a little bit of a coil protruding out or something like that, but you wouldn't, there's no risk of them migrating somewhere else.
So you don't have to remove it.
You don't have to remove it. However, there are cases that we've done where you do have to remove the coils if there's a recurrence and you actually can't dissect around the aneurysm well enough. In those cases, and I once again, I have more case videos of these as well if you guys are interested, we actually do have to remove some of the coils so you can see the aneurysm neck well enough to place a clip across it. Because the coils, the thing about coils is they create a mass there. With a clip, you're just putting it at the neck itself, and then the aneurysm will kind of involute and thrombose off over time and shrink. But with coils there, you continue that mass effect, which somebody has a cranial nerve palsy from an aneurysm, which is common. That's kind of one of the reasons why you might want to treat them with open surgery, because you can actually decompress the nerve right away versus putting coils in there, and then you'll have a mass effect still on that nerve.
So I guess a secondary question would be, do you know if there's been complications from people that have had either one of these options? With my thought process goes to foreign body, foreign matter in the human body, us recognizing foreign pieces of, I'm not sure what this coil is made of, but has anybody rejected it or had a complication afterwards that you would have had to have went in and removed it and done something different?
That's a great question. Not typically like, with a transfusion related or, like a graft to host or host to graft. None of those type of rejections. What does happen though is whenever you place something foreign in the vessel, it starts to promote clot. And actually that's what we want to happen. We want thrombosis within the aneurysm itself. We don't want thrombosis or thrombus formation in the normal vessel. So for instance, the middle cerebral artery, which, supplies the motor to the contralateral part of the body, and if it's on the left side, does speech and all these things. We've seen, cases we're treating an MCA aneurysm with coiling, and there'll be a little bit of clot forming there. We don't want that to happen. So that is the body's own kind of reaction to something foreign within the vessel itself, but nothing more on a systemic level. It's usually just at the local site.
Okay, thank you. I appreciate that.
I have a question to stem off of that. So I know that a complication for the clipping can be like later in life, a patient, going through MRI and that clip can move. Is that an issue with the coiling as well, or does that kind of remove that risk?
So typically the clip does not move in MRI. That's like an old, like almost all clips now are MRI compatible since like the 1970s, 1980s. So every once in a while we'll see a patient that says they had their aneurysm clipped in the 1960s and they were told that their clip is not MRI compatible, and then they don't get MRIs. There's other studies that they get, but no, and certainly not with endovascular therapy either. Actually, an MRI is even better to see the coils. There's not as much of a metallic artifact with CTA or with CT. Well, you do clipping as well, but coiling as well. Coiling even more so, I should say. There's a metallic streak artifact that happens, and it looks like a kind of a starburst pattern. So you can't really see the tissue as well as you can. So MRI is actually preferred in both clipping and coiling compared to CT.
Cool. Yeah, I asked because we actually just learned in one of our lectures this week about that. So I'll have to email my professor and be like, well.
Yeah, and that's the old mantra. I remember learning that too in medical school, that the clip will move. And, the reason why they teach that is because it unfortunately happened to a few patients, I'm sure, back in the day. And that's also why they made these clips MRI compatible now.
Cool.
Looks like we have a question from Alec Curtis.
Hey, yeah, I have a question, and my apologies, I'm just new to reading research, so I just need some help pointing out some things in the paper. And the paper overall being about the endovascular technique versus the clipping. I don't see the data, at least in the tables that I reviewed, the comparison directly to the clipping. So I was just wondering if you could help me out and compare it to clipping specifically.
Yeah, so that's a great question. This paper was not meant to compare the two. There's been some great trials, prospective trials, which is better data. That's the best data you can get, is a randomized controlled prospective trial. This is retrospective in nature, so it's just looking back at what happened, right? So a prospective trial, and the two best that have come out, the initial one was called ISAT, which was the International Subarachnoid Aneurysm Trial. And what they did is they randomized patients throughout major centers. It was an international trial, to clipping or coiling after they had a rupture. So, somebody would come into the hospital, they present with a subarachnoid hemorrhage from an aneurysm, and they would put them in the study protocol, and real quick, they would treat them with clipping or coiling. What ISAT showed was that clipping had less of a recurrence, but coiling was actually associated with better outcomes. And that trial was a landmark paper that really changed the community, saying endovascular isn't just this goofy, kind of wild treatment. It's actually the patients do better. And the percentage, they were about 8% better in that trial. And I advise all of you to look that trial up, as it will, if you're going into neurosurgery, it's one of the landmark trials. It's called the ISAT. There was another trial called BRAT, which was the Barrow Ruptured Aneurysm trial, that I talked about a little bit, but they have data from 1 year, 5 year, and 10 year. I'm sorry, 1 year, I think it's 1 year, 3 year, and 10 year. And they compare coiling to clipping directly. Now, the endovascular proponents will say, well, that's just primary coiling. We don't really do just coiling now. We use stent, we use flow diversion, we use intrasaccular diversion. So all these newer technologies need to be compared against clipping going forward. So, but good question. I would advise everybody to check out those papers, because they're very interesting.
That answered my question. I was just got confused on the summary page, partly being here's the numbers, and I was just kind of unsure what to compare those to. I guess just comparing the neck versus no neck is more of what the paper is about. So thank you.
It's more about if there's a neck, what's the risk of this neck rupturing?
Yeah. Thank you.
Hey, Dr. Young. Michael here. I should have introduced myself earlier. I'm Eddie's counterpart in starting this energy group. So thank you so much when he said that you were eager to help us out. We got even more so. So appreciate it. You alluded to this a little bit, but in terms of medical management of aneurysm, especially ruptured aneurysm post after it's been ruptured, I saw a recent study that came out. I think it was University of Maryland, but it might have been multi-institutional, talking about low dose heparin versus like subcute, like Lovenox kind of in relation to cerebral infarction and neurological deficits. I was curious what your thoughts were on that. I know that anticoagulation is kind of a big question in a lot of neurosurgical procedures right now. I was curious if you guys, what your management strategy is at Carle Clinic, and then how you see that personally.
Yeah, that's a great question. So I think I know which paper you're talking about, and that's actually talking about delayed cerebral, vasospasm, which I don't know if you've heard of, is one of the major problems with aneurysmal subarachnoid. In terms of subcute heparin or low molecular weight heparin, Lovenox, once the aneurysm is secured, we typically are okay with doing it the next day with a stable head CT, because the thought is these patients, most of them come in pretty devastated neurologically, and their risk of DVTs and PEs is quite high because they're not going to be mobile. They're going to be bedridden for quite some time. And the risk of bleeding after we've secured it is low, right? So we'll put them at our institution, we'll put them on sub-Q heparin. And in terms of vasospasm, so for those that don't know, vasospasm is this incredibly complex pathophysiologic mechanism that we still don't know. It's one of the most widely studied disease states in neurosurgery, and actually was even, noted years and years and years before modern medicine, that after somebody would collapse from an aneurysm rupture, by day 4 to day 14, they would actually worsen. So what happens is the blood that ruptures from an aneurysm, it sits in that subarachnoid space and it forms a clot there. And that clot doesn't go away right away. And it's actually blood, in the blood breakdown products are very irritating to the normal vessels. So what happens is they actually go into spasm. And a lot of times that can be okay. There's not a lot of clinical significance. When we do angiograms or we do CTAs, we'll see that they're narrowed, but the patient's they're unchanged, right? Where it comes into play that it's a problem is if it's in the MCA, the middle cerebral artery, the anterior cerebral artery, the internal carotid artery, and they stop getting enough flow to significant, very important parts of their brain, such as their motor to their leg or their arm or their speech, and they start having clinical problems. And there's been a lot of studies recently. I think this University of Maryland study you're talking about was discussing in terms of vasospasm. If not, there's been other ones that have been talking about antiplatelet therapy, because it actually will help decrease the viscosity of the normal blood, and therefore they'll be better in terms of there'll be better flow by decreasing the viscosity with antiplatelet or anticoagulation. So that's kind of what our thoughts are currently about vasospasm and treatment of DVT-PE.
Yeah, that's great. Thanks. And yeah, they were talking about vasospasm. I think they were looking more clinical, just delayed neurologic deficits in general, which could be maybe a couple things, but yeah. And then I just had a kind of an unrelated question. I recently had a conversation with Dr. Arthur over at Sims Murphy. Yeah. And he said that he hopes kind of one day that, vascular neurosurgery neurointerventional vascular neurosurgery, that kind of specialty will become its own residency. I was curious what you think about that. That sounds like a novel, interesting idea, but I was curious what you thought.
Yeah, I'm actually glad you brought up. I kind of wanted to segue into this kind of towards the end of the talk, so this is good. You know, for those that don't know, there's actually three pathways to get into neuroendovascular, neurointerventional. They have all these different names: interventional neurology, interventional neuroradiology. And the reason why it's not just called endovascular neurosurgery or neuroendovascular surgery is because you can start off as a neurologist, then do a critical care fellowship or a vascular neurology fellowship, and then do an interventional neurology fellowship. You can go through neurosurgery residency and then do an endovascular neurosurgery fellowship. And you can also start off as a radiologist and then do an interventional neuroradiology fellowship. So there's three different specialties that all come into the field of neuroendovascular surgery. So the thought behind just creating it as a residency is a very novel one, but it kind of this is a little bit more politics of everything, but he's getting at is everybody's egos kind of come into play with whoever they were trained and whatever, and if we kind of got rid of the three different pathways, I think that it would just be everybody started in this residency like they did for neurosurgery, and it would leave less to the ego game, I guess, in terms of who decides to do what cases. So, but I think I don't know.
Yeah.
I think it's interesting. I don't know how that will ever evolve though, because you already have so many neurologists, radiologists, and neurosurgeons that all went their own way in the field, that you'd have to kind of then diverge the field again. You know, so I don't know exactly his plan for that, but I don't see it happening in the near future.
Yeah, I mean, I think it was definitely theoretical. And just for everyone else out there, and you know, if that's something you definitely want to do, there's even multiple ways to go through interventional radiology pathway. So if you have questions about that, just reach out to me. You can go RADS, you can go directly in IR, or you can do these new early specialization in IR programs. Obviously, I'm biased to neurosurgery, but there are a lot of ways you can go.
Yeah, that's
kind of hard to.
Kind of what I wanted to touch on. I'm glad you just brought up that last point, was that, you know, unfortunately, you know, we all know neurosurgery to match into neurosurgery, it's pretty competitive, and you know, it's an uphill battle for sure. And I definitely want to help anybody along the way. That being said, if you know that you want to be in this field and, you know, for whatever reason you don't match, the neurology to interventional neurology or the radiology to interventional neuroradiology pathways are a little bit easier to get to match into and then to stay in those pathways. So I hope you all match into neurosurgery if that's what you want to do, but you know, the numbers will say that might not happen. So there's definitely ways to do something in the neurosurgical field that, you know, you can be very passionate about. And you know, if you guys have questions about those pathways as well, I'm happy to help out.
Awesome, thanks. So it looks like we got about 10 minutes left. So if you don't mind, in the last 10 minutes, maybe the first 5 minutes, you kind of just maybe retouch on the few pearls you'd want everyone to take away from this and say, remember in the next 6 months, because obviously remembering all the detail, it's not that likely. And also maybe kind of discuss your experience going through the neurosurgery process, the match process, being a student, being a resident, and then maybe the last couple of minutes, if anyone has any questions for you, they can reach out. And if we run out of time, I can get them in touch with you directly to field any other questions.
It sounds great. Thanks, Eddie. So basically, I think what we should take away from this paper is that obviously it's a new field for some of you. And some of you exploring a new field of endovascular neurosurgery, and that there's different ways to treat aneurysms, and there's different ways to treat ruptured versus unruptured aneurysms. But what this paper showed was that endovascular means, which are obviously less invasive, you know, going through the artery versus an open craniotomy, might not lead the best radiographic result, meaning you're looking at a neck remnant and it makes you, you know, the practitioner a little uneasy. However, with this paper and several other papers, they show that the risk of this bleeding, even though it doesn't look completely perfect, is incredibly low, and especially for unruptured aneurysms. So we, you know, like Sarah showed that statistic that 1 in 50 people, I mean, think about that number, 1 in 50 have an aneurysm. And, you know, aneurysms are very scary because a third of patients will die. a third of patients will have severe morbidity, lifelong, and a third will recover to where they were, their baseline. So we're talking 2/3 of patients that have a ruptured aneurysm their lives will never be the same again. Their families' lives will never be the same again. So if we can find these aneurysms early and treat them while they're unruptured and protect the dome and leave a little neck, I think we can be more aggressive about treatment, and be safe. And this study helps show us that we can still be safe by not completely occluding the aneurysm and risking, a stroke from parent vessel occlusion. That being said, we also do, in neurosurgery, we do clipping. So clipping is not this, great monster that it's an open surgery and 10-hour case and patients are in the ICU forever and they never recover. That's not the case. Clipping has evolved as well. We now do 3-centimeter incisions like we did yesterday to clip a middle cerebral artery aneurysm. And that patient, I just did an angiogram on her. She's fine. She's going to go out of the ICU today and she'll go home tomorrow. So that's 2 days. So as applicants interested in neurosurgery, you should always understand that there's clipping and there's endovascular and open surgical options. And like I said, it's a whole longer talk about which aneurysms are best suited for which, but just know that there's tools should be in every neurosurgeon's toolbox. Even if you don't perform endovascular treatment or clipping, you should at least know that there are people out there that do, and both treatments in the right hands can be the right answer. Then you wanted me to talk a little bit about kind of my pathway to neurosurgery. Is that right, Eddie?
Sure, or anything you think might be important to share, or whatever you like.
Sure. So I knew that I wanted to go into neurosurgery when I was in high school. And for better or for worse, I just kind of put my head down and didn't look at anything else. So I will say neurosurgery is obviously, the longest residency out there. I'm in my 6th year. I feel like I've been doing this for 15 years and I still have, my chief year left and then 2 years of fellowship, which I am self-inflicting upon myself, but it's an incredible fellowship. And actually Dr. Ogilvie will be one of my mentors, and he was on this paper. And anyway, but what I will say to everybody is, now that you have support from a group like this, and like I said, myself and my fellow residents and anybody, we're always there to provide any insight, to provide any tips that might help. If you have any questions, any particular situation, everybody's in a little bit different spot. But Eddie will share my email with all you guys, and I'm happy to help and answer any questions and point you in the right direction. I didn't have that, so I kind of had to scour through, the student doctor network or these other forums that were out there, a few years ago, and just try and find my way into getting my name on papers, getting associated with the right people. I will say for some of the senior medical students, your audition rotations or your away rotations, whatever you want to call them, those matter so much, especially now with the ACGME merger. I mean, you're not going to be able to probably go to as many programs and just try and, crush it at 10 different places. It's not going to be feasible. So, I mean, pick a few places that you really want to go to, or you think you have a shot at, and then you have, a relationship with already, and try and crank out some papers for them, get your, show up early, leave late, the typical stuff that everybody says. But that's what worked for me. I mean, I got my name on some papers. I showed that, I only wanted to do neurosurgery. I wasn't wishy-washy, like neurosurgery would be good for me, maybe, or maybe I'll do ENT, or maybe I'll do general surgery. I mean, if this field, if you're wavering on it, it's probably not for you. If you're 100% passionate about it, you'll love it, because, the hours are long. There's plenty of time where you don't see your family or friends. But if you are motivated about it, you will succeed, and you'll find yourself into a residency program. I can guarantee you.
Thank you.
That's awesome.
Yeah.
Dr. Young. Eddie, we do have one more question. I don't know if you saw that or not.
No, but go ahead. Looks like Dennis Wolf.
Yeah.
Yeah, if I came to your party late, sorry for missing much of what you said, but I was curious if you had any thoughts, or maybe have already discussed what impact going to pass fail for step 1 and Comlex is going to have on things, how you think that's going to affect what people look at. I've argued that it may make things like your mandatory rotations more important, your step scores there, because certainly something's going to have to replace kind of what's been, you know, we've got to have a step 1 of 240 or whatever, and or you're not really going to get looked at. Clearly what you said, the advice that I always give people is, if you want to do it, make it known and be passionate about it, exactly like you said. But something is going to have to kind of come in place where we're now pass fail, and the board scores are going to pass fail.
Yeah, that's a great point. I only briefly heard about that, that they were going to pass fail. Are they still reporting any score that can be used for residency application or no?
I don't know
So-
all the
So I can speak to that just a bit, Dr. Wolf. So step 2 will still be pass fail. Anecdotally, more people are taking step 2 before they apply anyway. And I think the idea is that since that's more of a clinical exam, people prefer that being a cutoff. Now, what the score will be, who knows, because those trend a little higher than step 1. There's actually a few surveys that have come out in the last year of program directors saying, gauging their perceptions on that. And one said that, you know, places where less prestigious schools, students from less prestigious schools might have a more difficult time, which you would expect. And the conversations I've had is that step 2 will replace it, but no one knows. And so I think that's the answer right now, but I don't know if Dr. Young has any other thoughts on that.
I mean, I would just go back, you know, like there are plenty of people that I know, and even some of my fellow residents, that did well, you know, upper 70th, 80th percentile, but not necessarily the 95th percentile or, you know, 99th percentile on their boards. But they had neurosurgical research on their application. They had really good letters of recommendation. Those carry more weight, I think, in the neurosurgical field than any other field because it's such a small field. So I would say, you know, get involved early with somebody, you know, in your town. It's somebody that has some connections in the neurosurgical field. You know, obviously we can't all, coming from, you know, osteopathic schools, we don't all have a big name chairman of neurosurgery at our institution. But I think if you can get involved with anybody that can write you a great letter of recommendation, I think that carries a lot of weight. I know it helped me. I had 3 neurosurgeons write me letters of recommendation, and I know everywhere I interviewed at, they were like, wow, you know, a lot of places, a lot of applicants have 1 or 2 neurosurgeons or 1, you know, general surgeon or what have you. So I think board scores, you know, becoming pass fail might even level the playing field for us a little bit, because there's plenty of our applications, hopefully, that won't just get tossed aside because of a, you know, just subpar board score. That being said, there's still, especially in the neurosurgical community, there's still going to be plenty of applications that will be passed over because of the, you know, the credentialing, you know, the DO behind our name, which is just, it is what it is. And you got to, you know, apply to the masses and try to get in with a few places that, you know, you do your research and know that they're DO friendly. I mean, I know there's plenty of neurosurgery residency programs out there that are, and I would say focus on that more than, you know, everything that you can control, try and control. And if it's out of your hands, then, you know, that's all you can do.
I was just going to comment real quickly. I agreed with everything you said. I mean, that's what my research said too. Letters of recommendation, ideally from somebody that the residency program that you're applying to knows, you know, so in the field and known is very important. The other thing that I was going to comment on, and I don't have the answer for this, but step 2, I've never seen people really blow it. I mean, it seems like there's a very narrow range of step 2 scores, whereas, you know, people will flunk the step 1 or, you know, come up with high 260s on step 1. And so it seemed to me that it would be really hard to establish a cutoff if in fact the range was narrow. I've only ever seen, you know, good scores. And so it didn't seem to me like that would be a discriminator enough for them. But that's a point of somebody who admits ignorance.
Thanks for that comment, Mr. Wolf. Looks like there is another presentation starting. So I think we're going to go ahead and wrap this up. But I will be sure to get Dr. Young